let's face it, staying informed today means cutting through the noise and quickly grasping the core of complex topics.
Definitely. Whether you're prepping for a meeting or just curious, you need those key insights fast.
Exactly. And that's precisely what we're diving into today. Understanding and applying logic models and the theory of change, specifically in, healthcare quality improvement.
And we've gathered some really insightful sources. We're looking at Joint Commission International, NABH from India, ISQA, and a great discussion from the QI Playbook podcast with Drs. Mehra and Desai.
Plus some foundational definitions to make sure we're all on the same page.
Right.
Our mission here is pretty straightforward. We want to give you a clear understanding of what these two frameworks are.
How they're different.
And crucially, how healthcare organizations can actually use them to make real improvements in quality. This should be valuable right away.
Absolutely. So where should we start? Logic models.
Yeah, let's unpack logic models first. In practical terms, what is a logic model?
Okay, so think of it like a visual map, a blueprint, sort of.
Yeah.
It shows the links between your resources, the inputs.
Inputs, okay.
The actions you take, those are the activities. The immediate results, your outputs.
Right.
And then the longer term effects, the changes you really want to see. Those are the outcomes. It maps the path to a goal.
Okay, that makes sense. Let's use that example from the QI playbook, reducing hospital-acquired infections, HAIs. How does a logic model map that out?
Okay, good example. So your inputs, the resources, that'd be your infection control specialists, maybe training materials, funding for, say, new cleaning stuff.
Got it. Resources in.
Then activities, that's what you do. Train staff on new rules, implement those new cleaning methods.
By actions.
And then outputs, these are the direct results of the activities, the measurable things like number of staff trained or how often the new cleaning happens.
Okay, specific numbers.
Exactly.
Yeah.
And finally, the outcomes. That's the change you wanted. A drop in HAI rates, maybe better patient safety scores.
And it seems really crucial there that the outputs have to be measurable, right? Like a number of procedures implemented needs to be something you can actually count or check.
Absolutely critical. If that link is fuzzy, the whole model kind of falls apart. It forces you to connect the dots. Did training lead to new actions? And did those actions lead to fewer infections?
It really highlights that connection. Buying equipment isn't enough. Using it right. That's the key.
Precisely. It brings clarity and, importantly, a way to track if you're actually making progress.
Okay, so that's the logic model structured step by step. How does the theory of change fit in? Is it similar?
Well, yes and no. While the logic model gives us that clear pathway, the theory of change, it kind of asks us to zoom out.
Zoom out? How so?
It's more about the bigger picture strategy. It explains how and why you expect a change to happen, usually over the longer term.
Okay, the how and why, not just the what.
Exactly. And critically, it includes assumptions.
Assumptions.
Yeah, the underlying things that need to be true for your plan to actually work. And it also considers external factors, things outside your control that could help or hinder you.
Interesting. Can we use another example from the QI playbook for a theory of change, maybe that patient-centered care one?
Sure. So imagine a hospital wants to improve patient-centered care. The inputs might be training programs, resources for patient engagement tools.
Similar inputs to the HAI example.
Right. Activities could be things like training staff to involve patients more, giving patients tools to give feedback.
Okay.
And the intended outcomes would be, say, better patient satisfaction scores, maybe patients being more likely to return.
All right, that still feels a bit like the logic model structure.
Yeah.
Where do the assumptions and external factors come in here?
This is the key difference. An assumption might be, we assume our staff are actually willing and able to adopt these new patient-centered ways. It's something you believe is true, but it might not be.
Okay, that makes sense, an underlying belief.
And an external factor could be perhaps new government rules about collecting patient feedback. That's outside the hospital's direct control, but definitely affects their plan.
Got it. So the theory of change forces you to think about those background conditions and the wider environment, not just the direct steps A to B to C.
Exactly. It's a much broader lens.
So if we were to really boil down the main differences, what are the key things to remember?
Well, the sources lay it out clearly. First, the focus. Theory of change is about the how and why change happens.
The underlying mechanics.
Right. Whereas the logic model focuses on the what of the program and when things happen, more operational.
What and when versus how and why. Okay. What about scope?
Scope. Theory of change takes that big picture view, considers those external factors, maybe even multiple ways change could occur.
Wider lens.
Yep. The logic model usually zooms in on a single direct pathway for a specific intervention.
More focused and detail level.
Theory of change is generally less detailed, more conceptual. It's the overall story.
The big idea.
While the logic model gets much more granular, step-by-step actions, specific outputs.
Right down to the details. So they serve different purposes then.
Absolutely. Purpose. Theory of change is great for initial planning, strategy development, and really identifying those crucial assumptions. Early stage stuff.
Makes sense.
The logic model. That really shines during program implementation, monitoring progress, and evaluating if it worked. More hands-on.
Okay, planning versus doing and checking. And how do they relate? Is one built on the other?
Generally, yes. The theory of change often provides the foundation. A good logic model should really flow from a solid theory of change.
So the logic model is like a practical visual slice of that bigger theory of change.
That's a great way to put it. It represents a specific pathway outlined in the broader theory.
I remember the sources used some useful analogies too, like theory of change answers why and how.
And logic model answers what and when. Yeah, those are handy.
And the other one, theory of change, is the big picture.
And the logic model is like a microscopic lens on one part of it. Helps clarify how they complement each other.
Okay, this is clicking into place. Now let's connect this to the real world. Healthcare accreditation, improvement efforts. Why do organizations like JCI or NABH care about these models?
This is where it gets really practical. These organizations, JCI globally, NABH in India, their whole reason for being is to drive quality improvement and patient safety.
Right, through standards accreditation.
Exactly. And logic models and theory of change provide the actual frameworks, the structured thinking, that helps hospitals meet those standards and achieve their QI goals.
So JCI talks about zero harm, high reliability care. How do these models help an organization actually get there?
Well, JCI works with hospitals to embed continuous improvement, use best practices. A logic model helps that hospital map out exactly how a specific initiative, say, improving medication safety, using JCI standards will lead to measurable results like fewer medication errors, the output, and ultimately improved patient safety, the outcome. It makes the link explicit.
And you mentioned the accreditation process itself can be team building.
Yes, apparently achieving JCI accreditation really forces different departments to work together, communicate better. Having a shared theory of change for why they're pursuing certain quality goals definitely strengthens that collaboration.
Makes sense. Everyone's pulling in the same direction because they understand the underlying why. What about NABH in India? Similar role?
Very similar, but tailored for India. NABH sets benchmarks, accredits hospitals. Logic models help hospitals define clear objectives and the steps needed to meet NABH criteria.
And the theory of change.
That encourages looking at the bigger picture in the Indian context. What systemic factors affect quality there? It helps develop more effective, sustainable strategies for improvement that fit the local reality.
So these really aren't just academic exercises. They're tools for meeting tough standards and, more importantly, actually improving patient care.
Absolutely. And that example from Dr. Desai in the QI playbook is powerful evidence.
Right, it's the hospital discharge planning one.
Yeah. She described using both models, and the result was a 25% drop in readmissions, plus better patient feedback.
Wow. A 25% reduction that's huge. That really shows the potential impact.
It really does. It shows these frameworks can lead to very tangible, significant improvements when applied well.
Okay, and where does an organization like ISQA fit in? The International Society for Quality in Healthcare.
ISQA is all about promoting quality improvement globally through education, sharing knowledge, supporting health systems.
So learning about these models
Fits perfectly with ISQA's goals. Understanding and using logic models and theory of change helps healthcare professionals be more systematic, more strategic about improving care. It fosters that culture of continuous learning ISQA promotes.
It really feels like these are becoming fundamental tools, doesn't it? Especially if you're serious about quality and seeking accreditation from bodies like JCI or NABH.
I think so. Even the fact that services exist, like Supremediq helping with NABH accreditation, shows how important these structured approaches are in practice.
It all boils down to having that clear plan, understanding your assumptions, and being able to measure if you're getting there.
Well said. So, thinking about our listener, what are the key actions they can take away from this deep dive?
Good question. The QL playbook actually gave 3 really practical tips. First, use logic models to stay focused on outcomes when planning QI projects.
Keep your eye on the prize, basically. Map it out clearly. Inputs, activities, outputs, outcomes.
Right. Second, For those bigger, more complex, long-term projects.
The systemic ones.
Yeah. That's where you lean on the theory of change. Use it to really analyze the context, identify those assumptions, think about external factors.
Understand the whole landscape before you dive deep into one path.
Exactly. And third, remember these aren't static documents. You need to evaluate your progress regularly.
Check your outputs. Check your outcomes against both your logic model and your theory of change.
And be ready to adapt. Learn as you go. Adjust the plan based on what's actually happening.
Those are 3 excellent, actionable takeaways. Integrating these frameworks really can lead to more meaningful, lasting improvements.
So whether you're deep in the trenches of healthcare QI or just trying to quickly get a handle on how change happens in these complex systems, understanding logic models and theory of change is really valuable.
It provides powerful insights. And maybe a final thought to leave folks with.
Yeah.
Think about applying that why and how, thinking the core of theory of change to any system you interact with, not just healthcare.
Beyond the immediate what and when.
Exactly. Where are the hidden assumptions? What are the real drivers of change? You might uncover some really unexpected leverage points for making things better wherever you look.
That's a great challenge. Thinking about the why behind the what. Fascinating stuff.